All right, everyone. Thanks to the Critical Care Lecture Series team, Dr. Choi and Dr. D'Souza and everyone else. So we'll start with a case. You get a notification, the phone rings, and you have a 46-year-old male. They're found at home, only responsive to pain, lasting well 2 hours prior. Vital signs are normal except for a heart rate of 134. The GCS is 6, airways patent, pedal edema. There's a rigid distended abdomen, and they have an 18 gauge in place. And they'll be there in 5 minutes. So like 10 minutes later, they show up and you do your ABCs, airways protected. This is all from the chart review I did. Breathing, the patient's tachypnic with, quote, Kussmaul respirations. They're tachycardic and they're documented that perfusion was intact and disability of the patient's altered. Vital signs, you have a heart rate of 136. They're a little tachypnic and the glucose is 60. So can one of the interns give me a preliminary problem list? Mm-hmm. Yes, hypoglycemic. Yeah. Okay. They're also tachycardic. The respirations were noted abnormal and they're altered. We'll get to the rigid abdomen later. Um, in terms of hyperpnea, just to kind of define it, it's like not just increased respiratory rate, but really deep breathing that you often see with metabolic acidosis as a compensatory mechanism. So, what initial interventions do we want to do for that problem list? Sugar, EKG, IVO2 monitor. Yeah. Uh, Labs, Rush. They're not hypotensive, but sure. You can sauna them as long as Silverberg's the attending. All right. So, uh, initial things that were done were the patient was placed on a monitor. They were given D50. They're given a liter of isolite, an EKG, and a POCUS were ordered, and all the labs. We'll get to that in a minute. The history is limited by the patient's mental status, but we speak to the daughter. She says she saw him at baseline 2 hours prior. He's been altered since then, and he's had this sudden increase in abdominal distension over the last couple of days. Past medical history, he has alcohol use disorder. He's a daily drinker as per chart review. He's had DTs. He was admitted 3 months prior for alcoholic hepatitis. He has known cirrhosis. He has no known drug allergies. So they do the exam. His cardiovascular is only documented to have tachycardia. He's in respiratory distress. His abdomen is distended and he has hepatosplenomegaly. He's jaundiced. In his neuro exam, they say that he is alert, but they also say that he's only intermittently opening his eyes spontaneously. He's not following commands and he's having asterixis in non-purposeful movements. So they do a sono, and not all of this is uploaded. How do I do that?
And then you get your phone out. Bam, 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 bam. Boom, bop. Yep. There we go. My email. Oh my God.
All right, so they do cardiac, pulmonary, and abdominal. Pulmonary, they just see A lines. I didn't upload those. They didn't record the abdominal ultrasound, the fast exam, but they said that there was no free fluid. And then, no, they just had abdominal distension. Yeah, maybe so.
Great. This is it, right?
Yeah, and it's limited.
Yeah, that's what I want. That's what I want. Can you give like an alt text to what
Oh, here we go.
it worked? It worked?
It just says requested access. Sure.
Okay.
Nice.
All right, we're good. We're back in. We are back in.
We have to do this every time.
Well, I think now we should be good, right? Okay. Now, boom, bop.
When you click on it, we stay up here.
Now,
It's
okay.
such a waste because it's not even a good ultrasound. It's just, I don't know.
Ask someone to explain it.
Was so worth it.
I know. But there's more media, so it was worth it. Yeah, so they just read it as hyperdynamic question mark decreased DF, no fusion or D sign. All right, EKG. Who wants to interpret the EKG for me? Tachycardic. Is it sinus? It looks like there's some P waves. All right, and then you notice anything else unusual? Peak T waves, yes. And then I also thought there's ST elevation in AVR with diffuse depressions, which can be seen with just global hypoperfusion. This is a sign of subendocardial ischemia diffusely. And this isn't usually, but it can be due to like a left main occlusion, but usually just like they're anemic or septic or they're just not perfusing for some reason. And so what's our initial differential, you guys, based on all of this? Mhm. Okay. Yeah. Yeah. Okay. Yeah. Shock. Hepatic encephalopathy. All right. All good. So we put this acute on chronic liver failure, which is kind of an all-encompassing term that includes, but is not limited to hepatic encephalopathy, which can be due to a GI bleed or sepsis. They could be acidotic or an acute renal failure, although less likely. They are hyperkalemic though. An intracranial hemorrhage, bowel perforation, and I didn't put SBP because they said no ascites and they're not febrile, but it's something to think about. So they're reassessed at this point after these initial interventions that we did in the blood work, and they're still just tachycardic. They're more tachypnic now. They're still saturating well. There's no other documented intervention. There's really not any other reassessment notes at this point afterwards. There's just this stuff. So they do testing. They order all of these things. A note about the ammonia level. ASLD does not recommend it. Routinely ordering these in patients with chronic liver failure because it doesn't really help or change management. It's not diagnostic or prognostic. However, if it is low, it can help you it can lead you to think about things other than hepatic encephalopathy. And then it can be prognostic in acute liver failure, which our patient does not have. So the VBG, does anyone want to interpret this for me? They have a big lactate. What do we think about the acid-base status? Like what kind of acid-base disorder is this? Is it appropriately? Yeah. Is this appropriately compensated? Yeah, if you apply Winners, it is. I mean, they're tachypnic, they're breathing off CO2. Okay. All right. So here's the labs. Can you all see that? I'll just read it off. So patients, I think it's not ugly. This is your workup tab. Patient has leukocytosis. Their anemia, they're anemic. Their hemoglobin's 7. Their baseline from like half a year ago is 10. They're thrombocytopenic. They're at 78. Their baseline's 110. They're acidotic based on the CO2 and the previous gas, and they've got an anion gap of 28. And we saw the lactate though. The K is 6.4. They have a slight bump in their creatinine from 1 to 1.26. The hepatic function panel is all over the place, but that is pretty much their baseline: low albumin, low protein, high bili, and elevated liver enzymes. And then there's a slight troponin elevation without a prior, and the ammonia is high. So the X-rays read is no focal consolidation or effusion. CT head is done. We got to do this again.
Go.
This is normal. I'm just gonna skip it. I just wanted it to look nice. Updated problem list. All right, what are all our problems now? Yeah. Yeah.
thrombocytopenia.
Yeah. Hyperbilirubinemia. Thinking of more like unifying problems. We said they had hepatic encephalopathy, an AKI or CKD with hyperkalemia. They're hypocalcemic, hyperlactitemic. I didn't write acidosis, but they're acidotic or acidemic. They're anemic. They've got synthetic liver dysfunction, given I didn't mention the coags are also abnormal. Troponelemia, which D'Souza got really pissed at me about. So a myocardial injury. Um, so additional interventions that are done after this. So the patient's hyperkalemia is treated. They get 4 rounds of albuterol, they get calcium, they get insulin. They're given a bunch of fluids, dextrose containing and not. They get 2 grams of ceftriaxone. Why would you give 2 grams? Does anyone know? The SBP prophylaxis, even though they documented they didn't think it was likely, but just because the patient's very sick. And then why would you give albumin in this patient? Yeah. So suspected hepatorenal is why they did it. They don't technically meet criteria. You got to be cirrhotic with an appropriate creatinine rise over the last couple of days. It has to be acute. And then they have to fail to respond to removal of diuretics and albumin challenge over 2 days, which this hasn't been done, but they were concerned for it. The patient's very sick, so they gave it. And they order a CT abdomen pelvis and they consult ICU. So ICU comes down. They say they're concerned for an alcohol withdrawal seizure given the lactate. They say give lactulose. They look at the guy and they say intubate him. He doesn't look good. And then they say admit to MICU. So patient's intubated. They get prop and rock. Any thoughts on the initial settings and why they were chosen? The blood pressure he was hypertensive. I think like 150 is systolic. Yeah. Yeah. Any idea why they would do that respiratory rate? Yeah, he was breathing fast. They're trying to help him compensate. They don't want it to hypoventilate him when he has a metabolic acidosis. So this is done. He's admitted now. They put the NG tube in and puts out a bunch of coffee ground emesis. His MAP drops to 50 immediately, and this is all documented after the fact. He's given a bolus. They down titrate the propofol. They repeat labs. His hemoglobin's 4.7 from 7 point whatever now. MTP is activated. He gets 5 units of PRBCs, 4 units of FFP. They didn't take him up. They wanted to keep resuscitating him in the ED at this point. So it's the next team after sign that's doing this. GI is consulted. And they come down, they actually see the patient in the ED. They say the patient's hypotension and drop in hemoglobin cannot fully be explained by only 200 cc's of coffee ground emesis, so probably something else, not varices or not something upper. They're going to do endoscopy when he's stable. The hemoglobin's higher. But go ahead and treat it as a variceal bleed with these things: octreotide, ceftriaxone, pantoprazole, vitamin K. And they send the patient to CT. I do want to show this one. They plan to send him for CT, and he's going to go to the ICU after he gets the CT done. It was just recommended. The patient had already been covered. Yeah. All right. Shared.
Oh. Okay. Okay.
Pause it.
Go back. Just go back. We're good. We'll be okay.
Yeah.
We'll be okay. Oh my God.
The mouse, I can't use it.
No. Bring it. Bam. And then we're gonna glide it over. Slide. Now I got it now. Yeah. Double
You all
click.
see that?
Double click the top. Double click the top.
I don't know if I'm at the top.
Got it.
I got it. All right. Everyone, I kind of scrolled too fast at the beginning, so just look closely. Slow down now. All right. Anything we see that looks weird? That's not poop. Yeah, that's all stomach at the top. So the stomach is just like massively dilated, full of blood. And there's poop below, I'm sure. Yeah.
Yeah.
Sure. All right. So the first thing from the view in the left upper quadrant is that, and they see that there's different levels of enhancement. So they think there is the stomach full of something. It looks like it's an active bleed. You see the NG tube in the stomach as well. And then they saw varices as well. All right, can I get my lecture back up? It was like 27, and it was close to baseline, but good question. Right. All right, so large volume of blood in stomach with active variceal bleeding, extensive varices in esophagus, stomach, and rectum. Patient goes to the ICU. All right, so now we're thinking the patient has acute on chronic liver failure with hepatic encephalopathy, perhaps precipitated by what we see now as a variceal bleed. And I'm going to be talking about the management of acute variceal hemorrhage in the ED. So that was an appropriate topic given that we don't always have GI anymore, and we might have to manage these more fully on our own. So background, this is the leading cause of upper GI bleeding in cirrhotics, which was surprising to me. It's up to 59% of the time that upper GI bleeds are caused by a varix, not always peptic ulcer disease. And the mortality rate has been shown to be as high as 30% per bleed with a 5-year mortality of 80% if they've had one. Just a little bit about the pathophys. You have a cirrhotic liver with high resistance. When the portal blood goes through it, it just has a lot of pressure to push through. So the portal veins dilate and then they can pop and bleed. So the goals of care, just very generally speaking, are to stop the bleeding, to maintain perfusion, to prevent complications. Stopping the bleeding, you want to plug the hole, and this is done by things like balloon tamponade, stenting, banding, or sclerotherapy. You want to lower portal venous pressures as well to decrease the impetus for further bleeding, and this is done by with octreotide or with a TIPS procedure. In the meantime, you're trying to maintain perfusion with blood products, and if they're not responsive to that and the other interventions, you can give pressors. And then you're trying to prevent complications, which is why we intubate or why we give like ceftriaxone. So in terms of airway protection, why would we intubate these patients? This is from James's lecture on why we intubate, but first for airway protection, if they're altered or if they're spitting up blood and they're at risk for aspiration. Also, they have a concomitant respiratory failure. Maybe they already aspirated and they're not oxygenating. And for their expected course. So for instance, if you think a Blakemore is going to be needed, you would intubate them for that if they're not already intubated, or if they need to go to endoscopy emergently, it might be a reason too. So considerations when doing these intubations, you want to have appropriate PPE. They may be having large volume hematemesis. You don't want to get that on you. Laryngoscopy, I think classically they tell us to go DL first. I think most of us are much more comfortable with VL, something you can try, but I would have DL ready and know that your camera might get obscured by blood. You want to have 2 suctions ready, and I would have a Decanto as well. Decanto is the large caliber suction catheters that we now have. I'd also have a flexible suction catheter ready as well, which I'll get to in a minute. A bougie just as an adjunct, and if you can't visualize the airway. NG tube, and I'd be ready to do a salad technique, which, oh, nice. How do I get over there? All right, this is just a quick video, but so basically this is just how to intubate a soiled airway. You're going to go in first with your Decanto catheter with the right hand, overhand grip, pull up a little bit, then go in with your laryngoscope. You've suctioned a bit now. You should be able to get a view of the cords. At that point, you slide the Decanto over to the left side and just like prop it up against the laryngoscope. It's going to be actively suctioning while you pass your tube, put it through, take the stylet out, and then before you put positive pressure on, you want to put the flexible suction catheter through the tube and just suction out any blood that could have gotten into the airway. Once you've done that, then you can hook them up to the vent or to the bag and give them pressure. And we're doing the procedure, Jim, after this. This is one of the things I'll have set up if you guys want to come practice that afterwards. All right. All right.
Do we have these flexible suction?
Yeah, I do.
Oh.
So yeah, the flexible suction catheters, they're not always in the recess. You have to go to the supermarket to get them. And then the Decanto should be right behind the yank hours, which I would use the Decanto. All right. Oh yeah, so next talking about giving blood products. So AASLD recommends a restrictive transfusion strategy. And this is due to the fact that giving more products could increase your portal pressure to the point that you're causing more bleeding or dislodging any clot. So they're really just telling us to target a hemoglobin of 7 in absence of comorbidities like some type of heart disease that would, make it 8 or hemodynamic instability. You want to give as little as possible to maintain perfusion. Just a little bit about managing the coagulopathy in liver failure. So it needs to be addressed. It's complicated. Cirrhotic patients have alterations that increase their bleeding risk. They have fewer platelets. They have decreased levels of coagulation factors, but they also have compensatory procoagulant changes like decreased levels of protein C and S as well. They also have elevated levels of von Willebrand factor, which is not produced by the liver, and they'll have decreased levels of antithrombin. So they can also be hyper or hypofibrinolytic. And so all this is to say that it's complicated. And if you just look at their coagulation panel of PT and an INR, it's not going to tell you exactly what's going on. And it may even understate the thrombosis risk, which these patients are also at risk for. So the AASLD recommends using a TEG in these patients. And I know we just talked about it a bit for the trauma series. I think there's better evidence for it in GI bleeds and cirrhotics, but there's no proven mortality benefit. They only show that you'd be giving fewer products if you used a TEG strategy, like they saw in this paper. Again, no mortality benefit, but it is useful to give fewer products in these patients just because you're trying to minimize the amount you give so as not to overly elevate portal pressures and cause more bleeding. In terms of pharmacotherapy, I'm going to talk about octreotide, ceftriaxone, the use of PPIs, TXA, and vitamin K. Octreotide is a somatostatin analog, which those do a lot of things, but in this case, it's just important that it's a splanchnic vasoconstrictor. It blocks the splanchnic vasodilation pathway, and this is going to mean decreased blood flow to the GI tract and decreased portal outflow, so decreased portal pressures. This is recommended by the AASLD guidelines that came out a few years ago, but the evidence is limited. It's low quality. The main study they cite is this 1995 RCT. They compared survival in octreotide versus octreotide plus sclerotherapy versus sclerotherapy alone. And at that time, sclerotherapy was the definitive standard of care. They found that the sclerotherapy alone group had a 71% survival rate at 5 days without rebleeding. And then the group with octreotide had an 87% survival rate. There's been other studies that have kind of corroborated this evidence, and this is why octreotide has become standard of care. But again, it's shown in the guidelines as limited, low-quality evidence. And if we're giving this, we're going to be giving a 50 microgram bolus, and then we're going to be starting an infusion at 25 to 50 micrograms per hour for 2 to 5 days. Ceftriaxone is also something that we routinely give these patients, and the rationale is that like a lot of these patients, up to 20% get a bacterial infection within 48 hours, and you want to prevent that. And the infection is associated with worse outcomes like rebleeding or failure to control bleeding or increased mortality. So we're trying to prevent these things. A recent meta-analysis looking at 14 RCTs found that there was no statistically significant mortality difference, however, in patients that got or did not get ceftriaxone with a variceal bleed, with an upper GI bleed in a cirrhotic patient, excuse me. The guidelines still recommend it. You'd be giving 1 gram daily, as was recommended by GI with our patient. But the takeaway is that the evidence is mixed. Guidelines do support prophylaxis, and this is a low-risk intervention in a high-risk patient, so something we should probably give. Also, PPIs are often talked about in these patients, and the rationale is that they're used for peptic ulcer disease and bleeding in PUD, so why not just use it for this as well? And also the thought that you're going to increase your gastric pH and promote clot stability, but it's been looked at by the NNT, represent, and even in peptic ulcer bleeding, the benefit is questionable. So there's no mortality difference. There was a 1 in 15 were helped in terms of preventing rebleeding, but even in this NNT, which was looking at an old Cochrane review, it looked like only Asian studies showed this benefit. In the Western studies, it trended towards actually harm. If you want to comment on that, Dr. Satapchi. Okay. All right, so the AASLD talks about using PPIs. They cite meta-analyses that show that there sometimes is a decrease in rebleeding, but again, there is no mortality benefit. The AASLD guidelines recommend stopping PPIs as soon as you have a confirmed variceal bleed, and they cite the risks of PPIs in cirrhotics, and these include microbiome disruption, which increase the rates of SBP, and the chance for increased chances of hepatic encephalopathy. So they're pushing against it unless there is another indication for PPI. So next we'll talk about TXA because TXA stops bleeding. There was a large RCT that was done a few years ago, the HALT-IT trial, and this was looking at TXA versus placebo in all-cause GI bleeding, and they found no mortality benefit across 12,000 patients. They also found that in the TXA group, the VTE rate was twice in the placebo group, so there was a large increase in complication rate that was statistically significant. And they did subgroup analyses that looked at variceal bleeders, and there was also no benefit for them with the increased risk. So this is not recommended. Vitamin K, I'll just speak briefly about it. It's not typically recommended for these cirrhotic bleeders. Vitamin K is going to increase production of coagulation factors, but if you're cirrhotic, you can't make coagulation factors, so it's not really going to help with that. And if they really need a product, if they really need these factors or other things to promote coagulation, you would just give the end product, not the starting point, the vitamin K. And this has been studied multiple times in GI bleeders and variceal bleeders, and it's shown not to be effective. So what the patients really need, though, like the things we just looked at were all kind of spurious evidence. They just need definitive therapies. They need to see GI or IR for it used to be sclerotherapy or now band ligation or TIPS with IR. So sclerotherapy is what used to be the standard of care back in like the 90s. And how it's done is kind of like treating varicose veins. You just inject in or around the varix with this really like potent sclerosing agent that's going to cause thrombosis of the vessel and it'll stop bleeding. And this shows a 90% rate of hemostasis. They started comparing this though to band ligation in the 90s, and they found that you had similar rates of hemostasis with what was cited in one big meta-analysis 95 that is cited in all of these guidelines. You have a decrease in rebleeding rate. The odds ratio of rebleed is 0.52. Mortality, the odds ratio is 0.67. And for bleeding-related deaths, the rate was half. So you have improvement in all of these outcomes by using band ligation instead of sclerotherapy. And also the number of sessions required to achieve permanent hemostasis down the line was fewer. So that was why it's also more convenient for GI. And the way it works, you take this multi-band ligator device and you're doing your endoscopy with that. You get your view with that. When you see the varix, you just go down to it and you like vacuum it up and you drop a rubber band around it and then you come off and you go to the next one and you just keep doing that until they're all banded off. And this is what's recommended by AASLD again. And they're saying that endoscopy should be done within 12 hours for all variceal bleeders presenting to the hospital or suspected variceal bleeders. And of course, this is combined with all the other interventions that we've talked about. TIPS is another thing that's going to be done for these patients. So TIPS is an IR-guided procedure, and they're just creating a shunt from your portal vein to your hepatic vein. The idea being that you're going to bypass this high-resistance system in the liver, and it's going to decrease your portal pressures, decrease portal dilation, decrease chance of portal bleeding. And so this is indicated for patients with recurrent variceal bleeding despite definitive therapy, or if you don't have, or for high-risk patients as a preventative measure. So it's used both to stop bleeding and to prevent bleeding. This is recommended by AASLD to be done within 72 hours of presentation or ideally within 24 if possible. So, if you don't have these things or if they fail and you just need like a last-ditch Hail Mary, then that would be when we go to balloon tamponade, which is something we should know, especially given we may not have GI backup and we may have to manage these patients for a long period of time or transfer them out. And this is recommended by the guidelines again, AASLD. It's for variceal bleeding in patients for whom hemostasis was not immediately or initially achieved. They say don't keep it in longer than 24 hours, and it's a temporizing measure awaiting definitive therapy. The contraindications are few as this is a life-saving procedure, so it's patients, if they're not intubated or if they're stable, they shouldn't get it, I think clearly. And then relative contraindications would be esophageal strictures or recent gastroesophageal surgery, specifically at the gastroesophageal junction. It's been studied. The studies are typically pretty small. They don't really show any, there's never been a proven mortality benefit, but they have shown that there can be good initial hemostasis. So how it works, and I'll send a video out about this again, and we'll also have this available in the procedure lab after conference. There's multiple parts. There's a gastric balloon at the very bottom, the small one. There's an esophageal balloon. There's a gastric suction port, and there's multiple ports for inflating the balloons and suctioning. And so you're basically going to intubate the patient. You're going to slide this into the esophagus, into the stomach. Once you think you're in the stomach, you're going to inflate the gastric balloon to 50 cc's. So you're not fully inflating it. You don't want to inflate it in the esophagus and cause a perf, but you just want to make sure in the right spot. I guess I'll add to this, you should have x-ray ready with you when you're doing the procedure. Once it's confirmed in place, you inflate it to a total of 250 cc's. You're going to hang it with traction, 1 kilogram weight, which is 1 liter of normal saline, like such. They've also shown you can do it with a football helmet like that. We don't have those. So once this balloon's in, you're going to suction the gastric port, and there's little holes at the tip of the catheter. You're checking for ongoing bleeding. You're then going to drop an NG tube, which you've pre-measured to know the depth to the gastroesophageal junction. And once you're there, you're going to suction to see if there's any bleeding above the GE junction from the esophagus. If there is, then at that point, you would inflate the esophageal balloon. And this is not inflated with volume, but with pressure. You take a manometer, like with the blood pressure cuff, you attach it to this, and you want to inflate it to 30 millimeters mercury. So that's that. Back to our patient. So hospital day 1, the patient gets up to the MICU after the CT was done. They have a large episode of melena. They're hypotensive again. They get an additional 7 units of RBC, 7 units of FFP, 1 unit of platelets. They get calcium chloride. They're on pressors, and they're on high doses. I think it's like 20-something for norepi. They're getting the other medications we talked about. Also, NAC, rifaximin, and lactulose are added in, which I won't get into that. I think Dr. Udad's going to talk more about acute on chronic liver failure in the next few weeks. GI comes in later that day. They attempt endoscopy, but they're unable to control the bleeding. A Blakemore is placed by the ICU attending at the bedside. They repeat endoscopy later on in the day. They band 5 varices. And then that evening, an emergent TIPS is performed by IR. On day 2, the patient becomes febrile. They're started on broad spectrum antibiotics. They have a 3rd endoscopy, which shows no active bleeding from the varices. Day 3, they have persistently poor mental status. They're having new myoclonic jerks. There's an EEG done that doesn't show any seizure-like activity. Yeah, so TIPS actually increases your rate of hepatic encephalopathy. It can increase the chance of it. So it could have been a worsening of that. Day 4, renal function's worsening. There's concern for hepatorenal syndrome. We'd given initial treatment of albumin. Now they're starting on maintenance therapy. The patient's still maintaining their pressor requirements. And they kind of stay like this for a couple of days. Then on day 8, an ultrasound is ordered by IR to check the TIPS, and they find that it's not patent. So the patient is rushed for emergent revision. They become hypotensive, and they start bleeding again in the IR suite. MTV's reactivated. And they get out of the procedure, the family comes, they have a goals of care discussion, the patient's made comfort care, and they make the decision to terminally extubate the patient that night, and they die that evening. So in summary, these are extremely sick patients. We may have them without backup now. Core management goals are to control the bleeding, that's plugging the hole, decreasing portal pressures. You want to maintain perfusion by giving restrictive transfusion. You want to treat pharmacologically. Octreotide and ceftriaxone are standard, although the evidence is limited. PPIs, it's kind of unclear. It looks like they don't really work or that it can make it worse. If GI asks for it, I would just document why you are not giving it. TXA is not beneficial. Vitamin K has no role here. And early definitive therapy is really what we are trying to achieve, either through transfer or through GI or in our own institution. So I'll send my citations and notes out, as well as videos for the Blakemore placement. Any questions, comments?